Good afternoon to all, but also good morning and good evening to many of us. It's our pleasure to welcome you to the ITM Alumni webinar organized in light of the International Women's Day, which is celebrated tomorrow on the 8th of March. In this webinar, ITM alumni and colleague Séverine Caluwaerts will talk about her experience of working in the maternity of costs in Afghanistan. The main aim of the ITM alumni webinars is to share research findings, expertise, but also experiences on a specific international health topic within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. I will now briefly explain some of the practicalities of this webinar. If you want to ask a question, you can use the Q&A option you have below your screen. If you want to ask a question in live, you can raise your hands. The chat is being disabled for questions. Questions will be moderated and only a select number of questions can be answered in live given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. At the end of this webinar, a short survey will be displayed and the browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM alumni platform and ITM YouTube channel. I will now introduce our moderator of today, Antene Asefa. Dr. Antene is a health system researcher with more than 13 years of expertise on global health issues, including maternal, sexual, and reproductive health, HIV/AIDS, and TB. He now works, currently he's a principal investigator of a mixed methods longitudinal study in Ethiopia and Guinea, which examines the link between the mistreatment of women during childbirth in health facilities and postpartum depression and health system capacity to improve respectfully maternity care and maternal mental health services. He's a research fellow at the Sexual and Reproductive Health Research Group at ITM Antwerp. Antene, please, the floor is yours.
Thanks, Charlotte, for the introduction and the invitation to moderate this session. Good morning, good evening, and good afternoon, everyone. And let me take the turn to introduce Séverine to you, our today's speaker. Séverine Caluwaerts is an obstetrician gynecologist from Belgium who has earned her diploma in tropical medicine from our own Institute of Tropical Medicine, ITM, and a master in public health from Liverpool University. Séverine has been working with both ITM and MSF since 2008 in different capacities and contexts in countries including Sierra Leone, Burundi, Democratic Republic of the Congo, Afghanistan, Pakistan, Niger, and Central African Republic. Of course, today she will focus on her experience in providing services in Afghanistan. Since 2011, Séverine is one of the gynecology referents here at ITM and also at MSF. Her special interest includes pregnancy and infectious diseases, cervical cancer screening and treatment in low-resource settings. She also continues to work as a clinician at ITM, and also she actively participates in our teaching activities in several courses, including the IIH and tropical medicine for nurses and midwives. I hand over the floor to Séverine.
Thank you so much, Antene and Charlotte, for this nice introduction. And thank you all for being present here and for your interest in sexual and reproductive health, women and babies in Afghanistan in general. So I'll speak mostly about delivery care because that is what I did there. It's my personal experience, but I also will speak about the wider picture. And on the eve of International Women's Day, I would like to show the screenshot of The Economist of a little bit more than 1 year ago, published also on an ominous date in the history of Afghanistan and the history of the world. Yes, you see it correctly, 9/11, 20 years after 9/11 happened and 20 years after the US decided to invade Afghanistan. So The Economist published a summary of research done by the University of Texas. And they looked at different societies and also like how societies are doing economically and how stable societies are. And societies that treat women badly are poorer and less stable. Of course, this is not that treating women badly causes a poorer society, but there is a strong association. Also, if they when they corrected for other factors, as they did, like for religious conflict, ethnic conflict, colonial history, and a number of other factors. So oppressing women not only hurts women, it also hurts men. So what is happening in Afghanistan currently, excluding women for many jobs, excluding women from higher education and secondary schools, is not only bad for the women, it's also bad for the men and for society in general. And also to show that everything is interrelated, these are data on female literacy in Afghanistan. They're all data because there are no recent reliable data, but what was published in 2021 that was that of the Afghani women more than 15 years old, 22% could read or write. And this is read or write in Pashto or in Dari, the two national languages. This is among the lowest figures in the world. Afghanistan has 34 provinces. You see, the only province where more than 30% of women could read or write is the capital, Kabul, where educational level is always higher than in the rural areas. I put an arrow in the province where I was working, in Khost. You see there 2% of the women were literate, and this did not improve significantly over the years. It was rare to have a patient there who could read or write. This is a selective picture of the 1970s. It is a true picture. This picture was taken in Kabul, somewhere in 1975. You see here young university Afghani girls going to university. This was real, but this was only real for 1% of the population that grew up in the capital, that had parents that thought education was important, and that indeed at that time in the 70s experienced a relative liberty. This picture, it has been said that it even has been used to try Trump to convince to stay in Afghanistan. Also to show that what for girls was normal in 1975, well, a selected small group of girls in 1975 has completely gone backwards nowadays in 2023. As you know, also Afghanistan has had a complicated and a violent history the last 40 years. It was invaded by the US in by the Russians in 79. The Russians stayed 10 years for a 10-year war. Afterwards, there was a few years of instability. And the Taliban came first to power in 1996. They stayed 5 years. In this period, female education was forbidden, access to contraception was forbidden, and women could not go out by themselves. When the second Taliban period came, after the 20 years of US oppression in August 2021, they promised they would be more lenient, that women would have more rights. But what is happening in practice is we see daily, weekly, monthly, more restrictions in women's liberties. So these are data from before the Taliban take over. Afterwards, there are no reliable data. It is a country with a high maternal mortality. I will come back to that on the next slides. Many of the births still happen at home. And also almost half of the women do not receive any antenatal care. On maternal mortality, the highest maternal mortality ever recorded has been registered in the Afghani Badakhshan province. Badakhshan is in the mountains, very close to Tajikistan. It's very isolated, and also it was during Taliban times. It was 2001, the end of the first Taliban rule. This is published in The Lancet. You find it back on the internet. And the article has like the very sad and ominous title, where giving birth is a forecast of death, maternal mortality in 4 districts of Afghanistan. The researchers looked at 4 districts, among which also the capital Kabul, where maternal mortality, where the figures were much better. But what they found in the Badakhshan province, and this was based on household surveys, was a staggeringly high maternal mortality of 6,500 over 100,000 live births. In normal human language, this means that the probability of an Afghani woman dying of complications of childbirth in her life is probably 1 in 4. It's that high that it's difficult to believe. But it was in the mountains, no transport, no skilled attendants, because female education was plainly forbidden and there were almost no female health providers, and men cannot touch other women's bodies. So this is what happens if you don't do anything. If women have complications, many of them die. Maternal mortality currently, the latest figures are 2017, and last week I looked because I knew the WHO report came out. The maternal mortality has improved significantly. You see it's a very big difference. It's now around 400 over 100,000. Means 1 in 33 women dies during a life in childbirth. Still extremely high here in Belgium. It's less than 1 in 10,000. But everybody looking into this data has a lot of questions also around these data. Why? First of all, maternal mortality is difficult to measure, definitely in the rural districts because of accessibility problems, security problems. So usually it's measured mainly in the big cities where it is anyway better. And the Americans who invaded the country in 2001 and who stayed 20 years were also known to use health figures for political reasons, like to do cherry picking in publishing results. And this improvement in 20 years is so spectacular that it is difficult to believe, especially for people who work on the ground and who in the rural areas saw little improvement or even no improvement. And as said, maternal mortality is always higher in the rural areas because of lack of doctors, lack of access, lack of education. And this is a publication from the Lancet Global Health of 5 years ago, where colleagues, one of them I met in Afghanistan is Hannah Tapis. She works for GPIGO. They did a maternal mortality survey, and they saw also what we have seen as MSF on the ground. Maternal mortality is 4 times higher in rural districts than in Kabul, the capital. So what was my job in Afghanistan? I worked as a gynecologist and obstetrician in Khost, a province on the border with Pakistan in eastern Afghanistan. Well, one of the difficulties in Khost was already when we started was determining the exact population of Khost. It was somewhere between 500,000 and 1.5 million people. There were no reliable surveys of the last years. And also the border with Pakistan is quite porous. People travel back and forth. We got at one stage an influx of 150,000 refugees from Waziristan in Pakistan. So when we started, we thought, we calculated, you can calculate according to crude birth rate, to population, how many deliveries you expect. We expected at least 1,000 deliveries a month. In reality, there are months at this moment where we receive and help 2,000 women and their babies a month. MSF has also a long history in Afghanistan. We were already present during the Taliban 1 period between 1996 and 2001. We left, unfortunately, in 2005 because of a serious security incident, and we came back in 2009 and have been in the country non-stop. We support not only maternities, but also a trauma center. And on this map, there's 5 projects. At this moment, there's already 7 or 8 because we recently opened a project in Herat, close to the Irani border, for malnourished children. And in the Bamiyan province, where we also are doing sexual and reproductive health, but at primary healthcare level. Bamiyan province maybe also rings a bell. The Buddhas of Bamiyan are quite well known. They were destroyed during the Taliban one period in, I think, around 2001, because the Taliban did not permit these statues of Buddha. They thought it was heresy. They destroyed them. So MSF's total budget now is around $40 million. And at one stage, when we calculated, according to population figures, the total population of Afghanistan is also around 40 million people. We were supporting 3 large maternities, some health centers. At one stage, 10% of all births, according to population figures, was happening in an MSF managed structure or MSF supported structure. I spent more than a year of my life in Afghanistan, for the first time in 2011 and for the last time last year, December, so 2 months ago. I'll show some pictures of the maternity, of daily life. In a very strict Islamic culture, it is difficult to take pictures of women. We also did not do it of security reasons, but to take pictures of babies, there is absolutely no problem. On the contrary, we always asked the mother, and the mother was basically delighted. We wanted to take a picture of the baby. So you see here premature twins. I think they weighed both around 1.6 kg around birth. Then this is the operation theater. We had 2 operation theaters. This is one of the delivery rooms with 6 beds. The other delivery room had 4 beds. So we had in total 10 delivery beds. And here, this is the building before there were any patients in the building. So at this moment, in Khost, we have around 1,800 deliveries a month. In busy months, it can go up to 2,000 deliveries. This means on average 60, 70 a day. So Khost is a very busy place. We employ more than 100 Afghani midwives. In 2021 and 2022, we had more than 20,000 deliveries a year. In 2020, we had less admissions. We think probably because of COVID, much more home births happened. We can speak later on the effects of the COVID epidemic. We work with 12 international staff, the majority women, and around 400 national staff, of which 65% women. All the midwives are women, the cleaners are women, also because they enter the patient's rooms. We employ many female doctors. The only men healthcare staff we employ are the pediatricians, because we don't find enough qualified women, unfortunately. And of the anesthetists, the majority are men, but we also employ 2 female anesthetists, 2 Afghani anesthetists. We give contraception after giving birth. The acceptation is quite high. As you can see, 3 out of 4 women accept. To be really honest, what we offer also is condoms, and like 1 in 3 of women chooses condoms. I am not sure if they really are using the condoms that they are intended to, but acceptation is very high. And if you see, like from 5-6 years ago, we only had 30% acceptance rate, which is, so it really has improved. We also do, if families want to, tubal ligation after birth. If, for instance, they have 10 or more children, if they had life-threatening complications, or if they had 3 or more cesarean sections and they want a tubal ligation, in the Afghani culture, it's a life-saving surgery, we do it. In Afghanistan, nothing happens without consent of the husband. So a husband also needs to sign for a cesarean section and definitely for a tubal ligation. But I also met concerned, nice husbands who said, my wife had a complication, a dangerous complication like a uterine rupture or eclampsia in a previous pregnancy. Please do a tubal ligation because I don't want to lose her. So sometimes even the demand for the tubal ligation was coming from the husband. But something quite specific also for Afghani culture is that there is a strong preference for boys in the culture. So to have 7 children is not enough. At least of these 7, 3 need to be boys. And we also had like sometimes the heartbreaking situation that a woman delivered a perfectly healthy girl and she started crying because she was sad because it was the 3rd girl in a row and she thought that her family or her husband would be angry with her. It is also a very strongly male-dominated culture. For instance, infertility is always seen as a female problem. Only in educated families, and these are not frequent in Gos, you can sort of explain that also the husband needs to be checked. The average parity, average children per woman in Afghanistan on paper is on average 6, but in the rural areas it is 7 or 8. What we see is it's on average more than 6. And this means families of 0, because infertility, as in all cultures, can be a problem, but also families of 15, and usually not all 15 children alive. Since that, MSF is working already more than 10 years in Afghanistan and with a maternity, we are very well accepted. We organize a lot of trainings on the field. Up until 2 or 3 years ago, we could send in also national staff to international trainings. We have sent Afghani staff to trainings in Belgium. But nowadays it has become so complicated to get visa that the only way to assure trainings is to send trainers to Afghanistan. Those of you who know maternal health, we organize ALSO courses, it's advanced life support in obstetrics, also basic nursing care and ICU care. And what we also do is we started by investing in this large referral hospital, but without admission criteria, everybody is welcome as a private MSF structure. But over the years, we are also supporting 8 of the 13 health centers of the Ministry of Health in the province with drugs, ambulance transport, and also staff salaries, because especially after the Taliban takeover, many of the staff had not been paid for at least months. And we are also supporting Gos Provincial Hospital, the provincial hospital of the province, with drugs, staff salaries, and materials. So at this moment, in this one of the 34 provinces in Afghanistan, around at least 2 in 3 of all births is MSF supported. We also published our data. You find it in Conflict and Health. It's this article, Provision of Emergency Obstetrical Care at Secondary Level. What we saw also, because we offered quality care and for free, was that the referral hospital was attracting too much of the normal deliveries that were not happening anymore at health center level, because also the health centers, very often the staff was not there, also was not there 24/7, and they did not have drugs. So we saw that the only way also to reduce the workload of the referral hospital, because we definitely did not want to go more than 2,000 births a year, was to strengthen the first line. And this is a picture of the opening of a new MSF-supported health center. We worked in the existing structure, but we also renovated and then did the necessary. So what do we look at in hospital? We look at indicators. We want at least to follow what is happening there. And of course, we want to do a good job. We look at it also together with our national Afghani staff. Some of even our female Afghani staff have become an international staff for MSF. We have one of our Afghani doctors who is now the deputy medical coordinator in Syria, and she will become medical coordinator one day. And we have also one of our Afghani midwives who is now working as an international midwife for MSF in a refugee project in Italy. And I hope that if that is what the women want, that many more will follow. We have far more Afghani male staff who work now as international staff, but it's much easier for men to travel and to leave the country and their families than for women. So our maternal mortality out of 20,000 births on average in a year is between 3 and 9 a year. When we started, I was not expecting such low figures. I had worked in similar referral hospitals in Africa, and I was expecting at least 20 maternal deaths a year. So this was almost surprisingly and in good news low. In 2020, also just to say, we had 6 maternal deaths and 3 of the 6 were COVID related. And there have been now publications in the literature and more are coming out that COVID indeed had an effect on maternal mortality worldwide, unfortunately. And it's also what we saw among other projects in MSF in Afghanistan. And there are other examples, like in 2020, half of our hospital mortality was COVID related, which was shocking. Also, as a comparison, in Belgium, we have around 100,000 deliveries a year. So in this one hospital, we do 1/5 of the deliveries as for the whole of Belgium. We try to keep our post-cesarean section infections less than 1%, and we manage up till now. Neonatal mortality in hospitals, so if we take all the babies together, it's 1%. If you look at in the neonatology, and that's only the sick and premature and asphyctic babies, it's 7 to 8%, and it also has improved over the years. When we started, it was 15%. We cannot intubate or ventilate. We don't have incubators, so the care is kangaroo mother care. We can give antibiotics, feeding and phototherapy, and CPAP for babies who qualify for CPAP, but that is the highest level that we can go. And we also do, next to the maternal mortality analysis, we do near-miss analysis, and we discuss them with in group with everybody who was involved in the care of the patient. A near miss is a patient who nearly died, but who made it thanks to probably also a factor luck, but mostly the good care of the staff. These are some pictures of the neonatology. You see there the basic CPAP and the babies. And so to conclude, of course, there are many challenges. One of the main challenges we have is a lack of qualified female staff. Midwives, we need a lot also, because our midwives also are, of course, part of the culture. So many of the midwives also have 6 or more children. We need people to fill the pregnancy leaves. We need people also, unfortunately, to replace the midwives who get married and who have a very strict husband and who cannot work outside the home anymore. Sometimes also the workload is too high. If there is a day with more than 100 deliveries, I'm always hoping there will be not a serious sick patient, because no one has time to look at her. We try to look for creative solutions for lack of the female Afghani staff. Unfortunately, we're still obliged to put a lot of international staff. We were thinking after 1 or 2 years, we will go to 1 international gynecologist together with the local Afghani gynecologist. But at this moment, we still keep the 2 positions. So this was my job when I was in Afghanistan. We also still have the international anesthetists. We would like also to have more female anesthetists and more female gynaes, but they are difficult to find. We also have national staff living with us, because the problem is, if you're not married as a woman, you cannot live on your own. You're seen as, how do I put this politely, like even like almost a sex worker. You're seen as bringing a scandal on the family. So as an unmarried woman, you need to live with your family. If you don't have family in Khost, it's a problem. So what we came up also with as a solution is Afghani female doctors who come from Kabul and who want to work with us can live with us if they are fine and if their families are fine with that. And I always found it really rewarding and an asset, because you live together also with these Afghani women. You learn a lot about the culture, you cook together, you talk a lot. It was very, very nice. We also do even better than in Belgium, like kindergarten, 24 hours, 24, 7 days in 7. Because the only way to keep the midwives working and the doctors working is to provide childcare and also to be sure that they can breastfeed during working hours. So the baby can stay in the kindergarten until the baby is 2 years old. And we also organized English and computer literacy, both for men as for women. What is going to be the future? Well, in August 2021, now a year and a half ago, it was remarkably quiet in Khost. Khost was always one of the provinces with a lot of violence because there was a CIA base there and the American army was there stationed for a long time. So if you purely look at safety, the number of violent incidents has decreased significantly since the Americans have left, because there's less bomb blasts, less attacks, and it is very clear the Taliban are the boss in the province. And also when you speak to the people and you ask in Khost, did a lot for you change since the Americans left? They say no, because Khost was always a very conservative, secluded province. And when the US was still in Afghanistan, they did improve life, but for a small part of the population. For the women living in Kabul, yes, they had a lot more liberties when the Americans were still there. But the women living in Khost, the leaving of the Americans did not change a lot for them. Already when we opened the project, we decided to stay at least 5 to 6 years, and now we hope to stay longer, even also because a lot less money is coming to the country for healthcare. And we see also that the global health situation of the country is deteriorating. There is a large discussion ongoing in MSF. What are the red lines? For instance, there is more and more restrictions for our female staff, that they cannot go out alone anymore. Would we accept if the Taliban say you cannot have any woman in coordination positions anymore? Would we accept that, or would we say no, like this we cannot work? And these are the really discussions ongoing while I'm speaking now. There's only a planned exit if the situation for Afghani women and babies will improve. We might have created a structure that no one is able to take over because of the free of care and the sheer magnitude of the structure. 20,000 deliveries is a challenge per year. And our largest issue now is, one, safety remains a concern, lack of qualified female staff and educational opportunities for women. For the safety, I will not go too far into that, just to say that since the beginning, we are communicating with the Taliban, at least indirectly. Also in 2011, when we decided to open the project in Khost, because it was clear that if you don't speak to all the actors in a conflict, you might become a target. And we knew that we should be accepted also by the Taliban. If not, it would be just too dangerous for us and for the patients to open a hospital there. This was a publication in Dutch in the Standaard. The newspaper also like that MSF, Artsen zonder Grenzen, has been always talking to the Taliban. And then the largest issue for the future and the most worrying for MSF is girls' education. As you probably know, and this is my last slide, secondary schools in almost all provinces are closed for girls since the Taliban took over in August 2021. And since a few months, also higher education is closed for females. We are extremely worried. In the beginning, MSF did not speak out for fear of offending the Taliban or getting into conflict. These two screenshots is of 1 month ago. On the right, you see like an MSF communication on Facebook. It was also in Dari and in Pashto and in English. I just put the English version here. The IEA are the Taliban. MSF says that we are extremely worried that female students cannot sit their education, their university exams anymore. And you see also the quotation, we need more female doctors, not fewer. And I personally was very happy that MSF finally decided to speak out, because our largest issue for us and for the country in general and for the women and for the babies will be educated females. If not, we will go back to this horrible maternal mortality of the Badakhshan province in 2001 of 6,500 over 100,000. At that stage, also the global maternal mortality in Afghanistan, so also Kabul, the big cities included, was around 2,000 over 100,000, which was among the worst figures in the world. And what we also see is because of all these restrictions, women who have had education want to leave the country, especially for their daughters. And also men who have had education and who have daughters say, my girls don't have a future. And at the left-hand side, you also see from The Guardian that at least in some provinces, the Taliban stopped chemists selling contraception. So we are also like watching and seeing what will happen the next days and weeks if we still can go on providing contraception for women and their families. So this was a snapshot from Afghanistan. If people ask me, will you go back? I say, of course. I still hope to go back end of this year for 6 weeks at least. And I would like to say Tashakur in Dari and Dira Manana in Pashto, which means thank you in the local language. And I hope there will be a lot of questions.
Thanks, Séverine, for the engaging presentation. I hope we are going to have several questions. I see some questions already in the Q&A box. Yeah, there are a couple of questions. Let me start with Willem's question. The support of MSF to host is remarkable. And how does the HARE/Sayat Mandi project, which runs 41 health facilities, including a provincial hospital, contribute, or how is the coordination taking place? Because like from your presentation, like the question, if I narrate it shortly, it sounded as if those organizations are not contributing to the success. And then do we really need to give all credits to MSF?
Yeah. It's a good question. So I did not go too much into detail about the healthcare system of Afghanistan, but maybe I'll just give a very short summary. So you have the public sector, indeed funded by the Sayat Mandi project. You have a private sector for profit, dysfunctional, but there is a private sector. And then you have the private non-for-profit as MSF is doing. Also in Khost, the concept is the hospital is a private MSF structure, but in other provinces like Lashkar, we work in a maternity of the government. What is chosen as model to work in depended at that time of the political situation, the safety, the affiliations, and the way of working. So it's I started with MSF in 2011 or a bit earlier, and I know there was a big discussion in Khost which model would be chosen and why. What I can say also is that Afghanistan's healthcare system and the funding, and sometimes people ask me like, you really must know Afghanistan after more than 1 year, and I'm like, no. I have only been in one of the 34 provinces and then in the capital Kabul, but only a few days. What I can say is only about Khost. The healthcare system was severely dysfunctional before MSF came. And the governmental supported structures, especially after the Taliban takeover, did not have any drugs anymore. And the staff, I can say one of our female doctors, her husband was working in the government. She told me that he had not been paid for 6 months. So I'm sure that at some level, the Saad Mandi project is working, the funding, but from what I saw, and I'm a doctor, I'm not a politician, it was severely deficient in the Khost province. And what happened also before the Taliban takeover in these 20 years when the US was still in the country, the US also let the aid depend on political affiliation. Like the more the governor of a province was supporting the US, the more funding was going to that province. So aid has also been used as a political tool in the history of Afghanistan. And I mean, I would be very happy with a stronger Afghani healthcare system, but the funding has decreased significantly after the Taliban takeover. And what we see on the ground is also far more malnourished children than 2 years ago. And we start to see now also far more malnourished pregnant women.
Thanks, Séverine. Another follow-up question from Willem. Have you been affected by the recent ban against female workers in Afghanistan?
That is a very good question. So this female ban came on the 24th of December. So we were all shocked. I remember it's a Saturday and MSF called me when I was at the Christmas dinner. And I thought it was the worst that could happen for the women and for the country. We have not been affected in any of the healthcare structures where we are working, and which is in 8 provinces up till now, but so what the Minister of Health has said orally to MSF in a meeting, but there is nothing on writing, is that there is an exception for women working in the healthcare sector. This has been said end of December. Up till now, we can still work in safety, but we don't know what will happen tomorrow. And he has also said that there are a few organizations, among others, the UN and the ICRC and MSF, that can continue to work in peace. But all this is oral, nothing is in written. And I have talked already too much, but we see the Taliban as one homogeneous group when we look at the outside. While from the inside, this is also 10, 15 different fractions with not all the same ideas on female education. They're all conservative, but some are more conservative than others. And we have the feeling, at least, that the Ministry of Health is in favor of female midwives, nurses, and doctors. But next to the Ministry of Health, you also have the Ministry of Vice. They are the ones checking that a woman is not sitting alone in a car with a man, or the ones checking that the woman is completely covered in burqa. These people from the Ministry of Vice are so conservative that for them the only important thing is that the woman should behave. So we wait, and the optimists among us hope that in 1 or 2 years, life will become a bit better for women, that also at high Taliban level, there will be a realization that that it's not good to keep women at home. Like my first slide from The Economist was that oppressing women does not only hurt women, it hurts men. But the pessimists among us think we will be in this bad situation for the women and the babies for the next 20 years or longer.
Thanks, Séverine. Next is an appreciation from Maria and a question as well. So the question is about bilateral tubal ligation. So shouldn't it be compulsory whenever you have surgical repair for ruptured uterus to do a bilateral tubal ligation, do you really need to ask for husband's consent for the procedure?
Well, it's really nice of you, Maria, because I know you are worried about the patient, and I am too. For her, the best thing would be not to get pregnant. But in Afghani culture, first of all, we allow autonomy to the woman. She still has the right to make decisions about her body. If she says, I don't want tubal ligation, we don't do it anyway. If she says, I want tubal ligation, we explain the situation to the husband, and we hope he agrees for the benefit of the woman, because a uterine rupture is 5–10% again, a rupture in the next pregnancy, and a high chance of mortality for you and for your baby. But if the husband does not agree, we don't do it for our own safety. And we are the guests in the culture. It's still the only way to function in the culture is at least to understand that in Afghani culture, fertility, having many boys, is the most important task of a woman. I'm now like generalizing. There are families in Kabul and a few in Khost that think that female education is really important. But for a woman in rural Afghanistan, for the majority, the most important is to have many boys.
Thanks, Séverine. Yeah, we're bombarding you with like questions one after the other. The next question is, MSF is known for speaking out against violations. Did this approach had an impact on access to populations that the organization served?
I'll specifically talk about Afghanistan because we have spoken out in a lot of other contexts. I think in Afghanistan, up till now, we have been really careful in order not to offend the Taliban, and rightfully so. Like security is very important, also security of our patients. For the speaking out, like in favor of female education in February, nothing happened. Like we were watching a little bit, like will we get like a remark from the Taliban that MSF should not say anything, or we are asked to leave the country, but nothing happened. It just could pass by. And we know also that there are Taliban fractions that are in favor of female education. But there are also things that we don't talk about in Afghanistan openly. One of them would be, for instance, access to safe abortion care. As you can imagine, Afghani law is very strict. We also don't do health promotion for care for victims of sexual violence, of interpartner violence in the Khost province, also to protect. So we are careful, and we don't speak out against everything, what we sometimes do in other contexts.
Thanks, Séverine. I would also pitch in like Maxwell's subsequent questions on the causes of maternal mortality in Afghanistan. What really prevented like the leading cause of maternal mortality in Afghanistan based on your experience, and what is the referral process for a woman who has like complications, or like for a neonate who has a complication and who should be referred to those central hospitals? Maybe I would also pitch my question here, because from your presentation, I also understood that, okay, like for people who have relatively good access to those hospital services, okay, we say like they give birth in those hospitals and they have a low chance of mortality. But how is the referral system? And for a woman who is having a high-risk pregnancy or complication from a rural catchment, how is that likely that she has access to transport and ambulance? And then how is a kind of like weaponization of healthcare, if any, in Afghanistan as compared to Syria? Because in fragile and conflict affected settings, we know that health facilities, health workers and ambulance are affected.
Yeah. I will also make a distinction between before Taliban takeover and after Taliban takeover. before Taliban take over, there were quite a lot of bombings, a lot of violent conflicts in the host province, and we had people trapped at home that could not travel for hours, with a complication because of the general insecurity context. And we know also from the really very far away rural parts of the province that women have a significant time to travel to the hospital. This said, the road network is reasonably good, and the population has quite good healthcare seeking behavior. Like I'm just back from Sierra Leone since last week. Even though home birth is forbidden in Sierra Leone, we think and we see that still most of the women deliver at home because it's like this in the culture. While in Afghani culture, women come quite early to the hospital, most women, and some of the women who have relatives in host stay with their relatives when they're 36 weeks pregnant to deliver in the hospital. The ambulance transport is a mix between MSF and the government. During the day, it's functioning quite well. During the night, it depends. But Afghanistan is a poor country, but is not as poor as I would say South Sudan or Sierra Leone, where I've seen situations where women were walking 3 or 4 days to reach the hospital. In Afghanistan, I have not seen this situation. I have the impression that most of the families know someone with a motorbike or with a car.
Mm-hmm. Thank you. Thanks, Séverine. I am going to merge 3 questions, and then let me present the questions as what is being undertaken now to bring in long-term health system strengthening in host, and then what is MSF stance, and then how is MSF interacting with Taliban, and then the overall health administration in terms of bringing in positive changes which could run for long-term, and then given the fragile context, like what strategies are being laid out?
Yeah, these are all very good questions. First, the communication with the Taliban is the easiest one to answer. Our medical coordinator, who is a woman, but this is not a problem for the Taliban, she is interacting regularly at very high level with the Minister of Health, who is a Taliban. And in the host province, before the US takeover, we were talking already to people of whom we knew that were quite high up in the Taliban. And now we are having openly meetings with them. It sounds maybe a bit strange, but just a personal example. Host has an airport, and I had tea at this airport with one of the quite high Taliban commanders. It sounds strange as a Western woman, but as a Western woman, you are seen also a little bit as a third sex. Not an Afghani woman, not an Afghani man, but still they are also curious. They don't see a lot of foreigners. And at that moment, the moment of having tea, everything was okay. And I think also the Taliban appreciated us being long time in the province. And what also played a role was in 2015, the MSF hospital in Kunduz was bombarded by mistake by the Americans. Maybe you remember. 42 people died, of which 42 people died, some patients, and also one Afghani doctor whom I knew personally. And the reason why it was bombarded was because MSF had admitted Taliban fighters because they were wounded, and we admit everybody who is wounded. And so the Taliban also saw that we took care of their fighters. The US was bombarding us, and somehow this improved the relationships with the Taliban. It's also a cynical story, but Afghanistan, unfortunately, is full of cynical stories. a little bit like we have a common enemy. Well, we are not the enemy of the US. No, and I am the first one to say that life for women in big cities was better when the US was there. But they also invested not billions, but trillions in this war, with 60,000 civilian deaths, so children and old people, and also thousands of Afghani young men dying. I think everybody on the world stage says like 20 years of violence, so much money, so much lives lost, and we are back again like in 1996.
Yeah. Thanks, Séverine.
And then the strengthening of the healthcare system, this is very difficult. And for me, maybe the most striking and a little bit sad thing is educated people want to leave. So if the midwives and the doctors and the nurses leave, who will be left to strengthen the healthcare system?
Yeah. Thanks, Séverine. You have responded to like two of these is the next questions. So just to mix the questions, we have one question from Ann Peters. What is the average age at first birth in Afghanistan? Yeah.
It's a good question. Most women do not know their age. So the staff looks at the face of the woman and they estimate a little bit the age. Before Taliban times, you could not marry before you were 16, but it was happening anyway. Now we have the impression that a lot more young girls are getting married. I think the average age for the first birth is, we estimate, 16, 17. And the stories, unfortunately, of people selling their children to earn money, they are true. I heard the same in Khost, and of staff telling me, I know of this family living there who sold their girl because they needed money for the other children.
Yeah, thanks. Some question pertaining to contraceptive methods. Are those methods now banned or illegal in Afghanistan?
Very good question. No, they are not banned. They are not illegal, but I took a screenshot of The Guardian of 2 weeks ago, like that the Taliban had invaded or raided a pharmacy where they were selling contraception. Yesterday, MSF communicated that at this moment, we still can give safely contraception in Khost, but we don't know what will happen tomorrow or next week. So it seems this publication in The Guardian was a quite isolated event for now.
Yeah, okay. A question from one of our participants. Residents of Khost will get care from MSF hospital, but neighboring mothers from Paktika will not get it. How do you see this one?
Paktika indeed is the province a little bit higher. Well, I see that the person asking the question really knows Afghanistan. We have sometimes people traveling from the Paktia province and we never ever refuse someone. So she is welcome wherever she comes. I even had a patient coming from the Badakhshan province. The patient spoke only Dari, and the population of Khost is Pashto speaking, because she had family in Khost, and she came for a safe and also for free cesarean section. She needed an elective cesarean section. And what we also see is like in Herat, so close to Iran, in the My1 project in Kabul, where MSF is doing pediatrics, malnourished children, there is a strong demand of the population to do also maternal health. There are gaps everywhere, and it is also good to see that even in Taliban times, men know that women can die in childbirth and that they see maternal health as a priority. But then also, let's be modest. We are an NGO. We are a big NGO, but an NGO can never be the solution for a healthcare system in a country that should be rebuilt. But how is the big question for the years to come?
Yeah. Thanks. Yeah, I also see like the fact that men now accompany their female partners to health facilities, mainly hospitals, so that could be taken as a way to also kind of like have a conversation with them and then engage them in future sexual, reproductive, and maternal health services. Maybe that could also be seen like as a positive side to build on that and then gain something as a like an opportunity.
Yeah, and I think maybe this presentation was also a little bit too negative. I also have seen a lot of caring men who told me like, save my wife, do the surgery, I love her, take care of my kids. I'm also always a little bit afraid that I will give a little bit too much the stereotype image of Afghani men oppressing women, while it is far more subtle than that. And I've known also Afghani men who told me like, I sent my 2 daughters to Iran, to an aunt, because in Iran they will have access to education.
Yeah, thanks, Séverine. Thanks all for the nice questions. Now I hand over to Charlotte for the final stages of this webinar. Thank you very much.
Thank you. It's up to me to indeed say thank you to Séverine for sharing also your experiences in this setting of a maternity hospital in Khost, and sharing also your insights on the challenges healthcare workers and women and girls are facing also in Afghanistan. So thank you very much. Also to Antony for the engaging discussion, and also to the participants for your questions. I would also like to ask you to complete the polling that has been launched. This will enable us to continue also improving and engaging the discussions during these webinars. Please also save the date for the upcoming webinar, which will take place on the 25th of April in light of the World Malaria Day. And in the meantime, I would say to all, stay safe, healthy, and thank you once more to Séverine and Antony for your engaging and sharing your insights and experience. Thank you. Yes, Anne, you wanted to share something? No. Okay. All right. So thank you to all, and hope to see you next time. Thank you.
Thank you.
Thank you.